year of a summer school.
It was your idea.
No, maybe also yours. Maybe also yours. Actually, it is one major problem. I spent maybe 20 years of my life, which is spastic movement disorder, and therefore I choose that as a topic. Of course, it could also be robotic-based movement therapy, or it could also be Parkinson's disease training methods. But I think the focus today, and this is what is one problem, beside weakness, beside fatigability, and maybe affective disorders, that is a major one in the very windy road to more movement. And therefore we choose maybe this option, because for retraining of voluntary movement, for treating affective disorders, fatigue, there is, from my perspective, and you will get the taste in my presentation, there is not such a strong tool available like we have as a focal treatment for spastic movement disorder, with this very, very severe poison we are using in blocking motor end plates. So therefore, those are the topics. So it's embedded in relearning, or actually reactivating of motor pattern. And it's embedded, of course, in a multi-professional, multi-interdisciplinary team. And actually, that was the second thing I really got as a taste when we talked. You are a person that's speaking on eye height, maybe with politicians and also with your team. So that's, I think that's a major advantage. So congratulations to your team that you have such a leader. Okay, so maybe I'm more comfortable here, and I have my cup of tea here. I did my fellowship in Houston, Texas, so therefore I'm allowed to have a cup beside. In Germany, it wouldn't be like that. So hopefully, so how it worked before, maybe you help me?
Yes. You just click on
Geht leider nicht. Ah, da, okay. Okay, so of course you have a right to see my disclosures. I will speak a little bit more about my affiliations and my engagement in Berlin and Potsdam. But of course, in the last 35 years, I had some relationships, of course, to the big pharma in terms of botulinum toxin producers. But as you can see, I'm together with Allergan, Ipsen, and Merz, and my biggest party event I ever had was in Dublin with the launch of botulinum toxin B, Elan. This was incredible party. That was the last time I was here, so I suspect tonight something. Okay, so now we are in a good mood. So I'm working as a rehabilitation physician by education, and a neurologist and a physiotherapist. I'm working in the biggest chain of hospitals in one city in the world, which is Vivantes. It's an artificial name, which was created after reunification in Germany. So this is a map of Berlin, the capital. This is about 3.5 million, and with the suburbs, it's a catchment area of 4.5 million, and those hospitals cover around 5,000 inpatients. I have the privilege to be in the only hospital which is in the west of Berlin that covers rehabilitation, neurorehabilitation. Actually, it was 12 years ago when I started that business, because before in that chain, neurorehabilitation was not a major issue. It was only an acute hospital. So therefore, it's maybe a parallel thing. And I, at that time, 10 years ago, I also met Bettina Quentin, and we both put ideas together and had the chance by money from the Western Oriental area to create an incredible robotic department, which is, I think, the best equipped in the world, together with Philadelphia and another place. Schönklinik also has a very nice robotic department. So in this smaller hospital, Spandau, I'm part-time head of department. The other part of my working life I spent together with my wife and my co-worker Ulrike Schwarz in this outpatient clinic. The name is, or our email address is Neurorehabilitation, but it's the name of the outpatient clinic is Neurology and Psychosomatics. So I'm the neurologist and psychosomatic, but my wife also is a neurologist and psychotherapist, as I am too. Academically, I got my education at the Charité. Then I moved to Innsbruck, got professorship of the University of Innsbruck, had my fellowship in Houston, Texas, and now I'm affiliated at the University of Potsdam and got a chair actually 1 month ago, only a guest chair, but it is, in rehabilitation science, So now definition, and then we start with epidemiology. I think it's also important to know how often that happens. So actually the story started in the 80s of the last, decade, I cannot say, 1980s, I should say like that. And a group of physicians, specialists in the field of brain and spine injury, met each other in New York and created a Delphi consensus on the definition of spasticity. So it was not neurophysiology, it was a meeting of people and they decided what is spasticity. And at that time, I think, so in the 1980s, when you remember what you bought at that time, new television and all that stuff, of course, it's very interesting then to think about, you know, the electricity that goes around and the computers and everything. And therefore, they end up actually with a reflex definition for spasticity. So velocity-dependent increase in stretch reflex was the definition for spasticity. And actually, a joke at that time was, did you ever met a patient that came to you with the question, could you treat my exaggerated patellar tendon reflex? No, of course we cannot. Maybe we cut, so the surgeon can do, but the neurologist cannot. And at that time, of course, neurology was much more a job doing diagnosis, not treating. And actually, I decided in my studying in medicine, I like to become a neurologist, but because I liked that, making diagnosis. And of course, it was in that time, 1980s, when we studied medicine. And I was actually also amazed about that idea that we can explain everything with all these networks and circles. Yeah. But on the other hand, I was grounded as a physiotherapist, and I thought spasticity is something different. And therefore I was very happy when Pandayan, interestingly wise, he is an engineer, not a physician. He headed the consensus group of, I don't know whether an Irish was with that group. It was sponsored by the EU, the Spasms group. I know French people, Belgium, German, I don't know. Pandayan is, I think, origin is, I think it's Pakistan, but he's a UK citizen and an engineer. But he had it and he published that nice definition, which fits much more what we see in reality, which is a disordered sensory motor control. Equalized involuntary muscle activity. And in the context of an upper motor neuron syndrome, so a cut off on supraspinal spinal control of the lower spinal networks. So that's upper motor neuron syndrome. And if it looks like motor activity, so you can measure with EMG. If it's EMG activity, then we nowadays call it spasticity. Of course, it could be an increased tendon reflex, but it also can be a clonus, it can be Babinski, it can be spastic dystonia, it can be associated reaction, and it can be phasic or tonic movement. What is spasticity also raises the question, what is not spasticity, excluding the negative features of upper motor neuron syndrome, which is paresis, fatigability, maybe, and that's still a discussion, what is with a reciprocal inhibition, could be that and that, but still a discussion. I discussed a lot with the old people. That also was part of the 1980 consensus. And it's also not the biomechanical consequence of spasticity, which is contracture. Contracture is not a part of spasticity. Therefore, surgeon cannot treat spasticity. They cut tendons, that's it. So maybe neurosurgeons can do, they cut nerves, and this is also a good treatment. So how often that happens? Actually, by number of people, the most important problem is stroke nowadays. 715 prevalence or incidence 150 per 100,000, and 1/3 to 40% developed velocity-dependent increase in muscle tone, I should say. MS is a major problem because much more spasticity, TBI, much more spasticity than stroke, but the numbers are low. But of course, when you are working in such a place, you have to deal with upper motor neuron syndrome, and you have to know what is spasticity, what is spastic movement disorder. Actually, the whole community to call it spastic movement disorder and not spasticity. Why that? Because in some people that suffer from upper motor neuron syndrome, this spasticity only develops when moving and not in the rest situation. And therefore, it's more connected to movement. So that's my own work, and that's just a literature review, and I looked to the different phases in stroke, following stroke, and there was this miracle that spasticity develops later, and we have to treat it later, but we can show just by looking to the literature that in the first days, velocity-dependent increase in muscle tone is apparent. So actually, I'm working in an acute hospital. When I go to stroke unit, 2 days after a stroke, there is velocity-dependent increase in muscle tone. Therefore, it's spasticity. Okay. Numbers rising from every fourth to every third developed. So then I did with Charité, my old colleagues, a nice study, I think, published in European Stroke Journal. And so usually I think German medicine service is like maybe in Ireland as a neurologist in outpatient clinic. Usually I have 5 minutes for my patient, maybe 10 minutes. And when I do injections, maybe 20 minutes. But in this study, we gained money to stay 2 hours with one patient. We invited patients that had a stroke years ago, and we gave them a questionnaire, the post-stroke checklist, where the patient themselves, herself, they could mark, I have a problem with mood, I have a problem with stiffness, I have a problem with incontinence, with speaking or cognition. And then we clinically evaluate, and then we did validated and reliable scales on that. And we found out, of course, there is a problem with mood, there is a problem with communication, there is. But in the multivariate analysis, when we put all data together, the computer programs spit out that the most important factor for negative quality of life is not embedded in the network. When you are not embedded in the network, when you don't have a nice mother that is with you, a father or a relative. And the second most important is spasticity. Much more important than I cannot speak, I have a problem with cognition, I'm incontinent. Why? Because mobility is altered. Okay, so that was a strong message actually to think more. And this was one part of many studies I did the last 15 years. This was the point that it could be too late actually to start with treatment, because it's a big problem. So of course we should something do before. Now we go a little bit a step back. Actually, I have 1 hour, I have to fill it. But I think it's useful to again think about what is spasticity. So what is velocity dependent increase in muscle tone? So all that distortions of the hand could be motor activity, like a fist, could be motor activity, but could also be a contracture. Or the intrinsic plus, intrinsic minus hand, or the elbow flexion could be muscle activity, could be contracture. And therefore, I think it's important to differentiate contracture from muscle activity in that case. And of course, it's always the same. It's a little bit of both. Yeah, and therefore, I think it's good to know. So when, let's make an experiment. So the experiment is you get electrodes, surface electrodes on your biceps, and then you stretch the arm. So when we stretch very slowly, nothing happens. When we stretch very fast, we get muscle activity from our reflex arc. In patients with upper motor neuron syndrome, where actually the main thing that the brain is doing is inhibition of the spinal cord. When inhibition is gone by a lesion, then with a slow stretch, I get muscle activity. And that's muscle tone itself. And of course, increased in spasticity. So also with low velocities, where in normals nothing happens, in patients with upper motor neuron syndrome, you get a muscle activity. So that could be a measure actually, and Pandayan's still using it. Actually, last publication from Pandayan 2021 in December, he used this surface EMG in flexors of the wrist and the elbow to measure spasticity, published very well. So that's a nice way to look at, but this is not the only feature. I also mentioned other features, and I like to explain what else, what is it? Of course, the exaggerated reflexes, but we should think about the the monosynaptic reflexes, but we also should think about the polysynaptic reflexes, because we have anatomically wise, we have an interminentia cervical, interminentia lumbar. Actually, there is spinal stepping generator, and this apparatus is for actually putting excitation in the spinal stepping generator. So there is disordered control in upper motor neuron syndrome. Then we have the co-contraction. Actually, co-contraction, that's still on discussion. I said this is the reciprocal inhibition. When I activate this one got an inhibitory impulse, and in upper motor neuron syndrome, this is dysregulated. Then we have the associated reaction. I imitate now associated reaction in my right arm. And then it could be like that. You sit down, you stand up again, and then it goes like that. That's associated reaction. So muscle activity that is, unwanted, I should say. And then we have release and flexor reflex afferences. This is always doing this. When the foot is touching the ground, the peripheral input from the sensory impulses and on the sole always doing that movement. And then we have spastic dystonia, a really peculiar thing, motor activity in antagonists and strong activity. So a lot of force in both muscles on both sides of a joint. So therefore is actually a fixating co-contraction of joints. So we looked at that spinal apparatus and we thought about which reflexes, interneurons are affected. And we put together, and what was the essence? It's a change in spinal circuitry from disconnection from the supraspinal control. So that's it. That leads to changes in motor neurons, different membrane potential, different regulation in the gamma system. But the main important thing for the spinal cord is not the efference, it's the afference. So what is coming in from the dorsal horn, 1A efferences, created a mixture and a distorted re-information, reflex information to the alpha motor neurons. And that ends up in that syndrome that is described, upper motor neuron syndrome, with minus and plus symptoms and the consequences. So in an, let's say, pure neuronal spasticity without any contracture, so in the early phase of spasticity, because contracture needs a little time to develop, because it's a deposit of collagen in the muscle, in the tendons, in the joints. It's a combination, always a combination, a very individual combination from weakness, velocity-dependent increase in muscle tone, and all the other features, and the sensory loss that lead to discomfort, pain, care restrictions, functional restrictions. And then there is usually very fast a change that I called contracture, but actually it's a change in muscle properties. So that is loss of muscle texture, loss of elastic properties, and increase in collagen. And this leads to complications in the musculoskeletal system, like shrinking. So in terms of physical therapists, physiotherapists, occupational therapists call it reduced passive range of motion or reduced active range of motion. And this creates a big hurdle, an additional hurdle in the system, additionally to the motor neuron activity. And therefore, the whole thing we look at is muscle overactivity plus shortening and contractures and loss in sarcomeres. So how to deal with it? And I think I'm also a member of the Royal College of Physicians, and a good friend of mine actually was the initiator of that, that algorithm, Tony Ward. And it's now published, I think, and revised the second time. So what we do is, of course, the first step always is physical treatment. That's what we do. And we have generalized measures like positioning in a wheelchair, positioning in the bed, how we do the transfer. So that's handling. That's, I think, the most important, the handling of the person with an upper motor neuron syndrome. And then we have focal measures like splints, casts, tapes, and very focal constraint-induced movement therapy or task-specific therapy or robots. So that's the first step. And we should not do only one thing. That's another message. We should do, of course, things together, integrated. So that means it's useless to stretch the wrist when the patient is not accurately positioned in a wheelchair, or the patient has no strong core to deal with the stretch. When there is need for medical treatment, then nowadays it's totally, it's not important. We don't talk about the diagnosis, why the patient has a generalized spasticity. So a stroke, a TBI, an SCI. No, nowadays we talk if it's, if it involves all four limbs and maybe the jaw also, could be spasticity too, spastic trism it's called, then we do oral treatment. And I'm really shocked, still shocked. We have only one pivotal good trial for one drug. All other drugs, no data, no data. Baclofen, no data. Only tizanidine, one good placebo-controlled trial in a small cohort, and still prescribed by every GP in spasticity. So there is no evidence, nothing. Actually, this is an old review, but there is another Cochrane review that claimed the same. So what we know, everyone will get side effects, severe side effects, when you increase dose too fast. So therefore, if you have to go with, because it's generalized spasticity, what should you do? Then you should go very slowly, and you should stop with every hint of side effects. And then you go slowly back, and then you try again. Okay, so if it helps, and it really helps not much, and rarely good effects, but if it helps, okay, you can combine with physical treatment. And I think where it's a good solution is in spinal cord injuries, because they have an intact brain and they can cope with the side effects. When you have a stroke, you cannot cope with side effects because you have neuropsychological deficits. You get baclofen, and then it's, a disaster actually. So therefore, baclofen comes into play, but not in an oral way, in an intrathecal way. So pumping baclofen directly in the spinal liquid, so the liquor, that's a good method, because the dose you can reduce by the factor of 1,000. And the drug has not to go to the oral tract, to the bloodstream, and only works where it should work, at the spinal cord, inhibiting the interneurons. And the good thing about ITB, actually, I I do a lot of ITB implants in my hospital because we are taking care of very severely damaged people. And the good thing is that it's a non-permanent thing. Actually, you can implant a pump, you use it for years, and then you stop the pump, and then you explant the pump. So why not? Much better than orals. Okay, but does that help with all that complication? And as I said before, actually, the consequence is, I should go back. When I go here, then we see the reflexes should be actually treated early to avoid all that contractures we see. So therefore, there is the question how fast complications develop. So downstream complications like this collagen development. So actually the bad news is it develops as fast as spasticity, so parallel. So usually in 4 weeks you have your first contractures when you don't treat well. So splints, positioning, everything. So what is with focal and multifocal spasticity? That's a little bit beside the pathophysiology, the topic of today. So in focal, multifocal, what does it mean? It means if one limb, maybe parts of one limb, so the fingers, the wrist, the elbow is involved in spasticity as it is in stroke. Or the lower limb, or as it is in TBI, there are drugs that are licensed for the upper and the lower limb spasticity, and that is the second review of the American Academy of Neurology. We have also in Germany a guideline, and in the guideline is the phrase, you shouldn't start with orals in stroke with focal spasticity. You should start with botulinum toxin, because the good news is botulinum toxin acts where you inject it, and it doesn't, overwhelm the whole system by side effects. It stays where you put it, and that's the good news. Of course, pharmaceutical industry tells us it's very difficult to produce, and therefore we have to pay a lot of money for it. We'll see in the future. So what's the principle? The principle we understand very well now. The basic science told us that this is the normal process of muscle activity. So this is a motor end plate, and the electrical impulse comes from here, and then the vesicles go to the membrane, spill out acetylcholine that activates the muscle, and then it contracts. So that's the mechanism. And as you can see, there are a lot of proteins involved. So the snare protein complex. And in evolution, the Clostridium botulinum develops a mechanism to cut these mechanisms. So we have botulinum toxin A, B, C, D, E, F, G, and we now have a botulinum toxin that kills Drosophila. So maybe that will be a treatment against malaria in the future too. But the A toxin cuts the snare protein, and therefore this vesicle will not come to the membrane and therefore cannot activate muscles. So that's the mechanism. And as usual in pharmaceutical products, also in this most poison, so it's the strongest poison we have in relation to the weight of the poison. A few molecules can stop the biceps, let's say like that. So we inject that few molecules, and then the biceps is stopped to activate for 3 months. And then the nerves regrow again, and the biceps is as strong as before. So we have a method to stop muscle activity for a certain time. Yeah. The higher the dose, the longer. The higher the dose, the more block. So therefore, when you put too much, breathing is blocked. So that's very dangerous. So you have to know where to put, and you have to know how much. So that's a typical disfigurement, I would call it. Therefore, there is no face, it's just a disfigurement. And actually, it's a good friend of mine in the upper part that imitates the position. But that's a typical position in the upper limb and in the lower limb. And maybe when you remember, when you see stroke patients, they walk like that. And in every textbook is stroke patient has to look like that. Otherwise, they didn't have a stroke before. But it's a complication. It's a complication. This is not a stroke patient. A stroke patient can have a stretched arm and can walk. So that's a complication. That's contracture and muscle activity. And therefore, I met that lady in another hospital where I was medical director for 12 years. I met her, and she was like that. And what was the reason for that? She was skiing in the Swiss, had an accident, fell down, her artery dissected, and she developed a major stroke. So now my consultant at that days has to put all the force to stretch the elbow. So this is muscle tone, real tone. No pain, and he could stretch the whole arm. So therefore, on the modified Ashworth, it's a 3, not a 4, not the maximum. And you can see here, she has still some connections left. She can move the thumb. And now imagine you have involuntary muscle activity, but you also have voluntary muscle activity. So it's overwhelmed. Sometimes a movement is actually caught in spasticity. And therefore, it's, I think, a good thing to stop spasticity in that lady, in the biceps, in the flexors of the wrist, in finger flexors, and also in some muscles in the leg. And how we do it, like ultrasound control injection. So we developed that method in the middle of the 90s. When I was in Innsbruck, we started with it. Nowadays, everyone is actually doing it. In that lady, we injected 14 muscles in the upper and the lower limb in that way. Of course, it hurts a little bit. Yesterday, I gave a course for physicians, a webinar, and when you use a little bit of anesthetic spray or cream, it's a little less of pain, but it has to be injected. Okay, so this is the humerus in the middle, and then we have the brachialis, and on the top, the biceps. So you can actually differentiate the brachialis and biceps, which could be important. As a physiotherapist, we know why. Some physicians don't know. So, and the good thing is, what you can do is you can do integrated. So you put botulinum toxin in the muscle, and then you stretch with a splint, for example, and you put toxin in the leg muscles, and then you put the patient on the treadmill or in the locomat or in a robot. That's what we are doing in my department. Combination of local therapy, ITB, and of course the different. And we also have therapists, not only robots. So that's the result. Did you remember my consultant when stretching the elbow? This is after botulinum toxin, 4 weeks after botulinum toxin. Not a problem. And of course, when the triceps has some activity, then she can do that. And in the end, she could hold a ball like that. She could manipulate an orange like that later on, and this was not possible. Tragically wise, later on, my wife also know her because we developed a nice relationship with her husband and with her and a therapist too, or some therapists. Tragically wise, she had another stroke later on, and it figured out that she has an Ehlers-Danlos. So a problem with tissue. So you see now she can hold up the arm. Okay, so that's impressive what you can do before and after. That's maybe passive function and now active function. Look how she walks now on the right side and on the left side. And you should know she's an ENT doctor, and she went back to outpatient clinic and treated and hold it with the left hand, the speculum, and with the right hand manipulation. So she was a full doctor again afterwards. So that was a miracle, we thought at that time. But actually the idea was when you do it early, and it's stupid, this video doesn't work. So I could show you on the left side spasticity and on the right side no spasticity, but it doesn't, I don't know why. Good. So then maybe we change topic. I have 5 minutes. Okay. So now we discuss a little bit, and this is also an idea I had together with Bettina Quentin. So I'm a physiotherapist, so I had open ears for that. So what's the major goal actually for the physician? For the physician, I think the first goal is listen to your patient and define goals, because it's useless to treat spasticity if you don't have a goal. Because sometimes you can stand on your spasticity, and when you treat it, then you lose function. So, and patient has, the major thing from a patient is I want to improve my function, passive and active function, and therefore goals are the most important thing. And the plus MPT is from Mrs. Quentin. Listen to your multi-professional team and don't do your decision by yourself as a physician. So, because the therapists spend much more time with the patient, and therefore they know, and also the relatives spend much more time, and therefore speak with the relatives. From that goal could be like that. I have to drink something, so reaching. And release here. So then the muscle selection would be, if I have like this, I should treat this to get reaching, and I should treat this to get opening of the hand. So therefore, this would be muscle selection. Then I told you have to inject botulinum toxin every 3 months to repeat the effect. So therefore, muscle, how many toxin per muscle, which intervals, then it counts whether you hit the muscles when you inject. Then it's important where the end plates are. You remember that motor end plates, they are in specific regions. And of course, you have to combine with adjunctive treatment, and together with Lynn Turner-Stokes and some others, we put that together. So a comprehensive person-centered approach. Actually, I recommend to read that one. That's a very good publication for multi-professional team, how you can work together. And what you have here, you have good physios, occupational, I learn. Maybe you have specialists for certain casting, you have neurorehabilitation specialists, you have nurses, relatives, you have, of course, patient, listen to your patient. I don't know whether you have a botulinum toxin specialist available. That would be one discussion, actually. For some patients, it's important. For others, it's not. But 40% of stroke patients does need such people. So talking about dose, maybe that's too specific for here. But are you doing botulinum toxin?
There are spasticity clinics that deliver.
Yeah, sure. So I did that study where we go up to 800 units of incobotulinum toxin. So we start with 200, only 2 vials, then we go with 4 vials, and we go with up to 800. And what we found out is the more you take, the better the results, of course. But you have to be cautious because the primary endpoint of that study was not efficacy. So you could see, and it was a nice equation. When you use 4 vials, you go down 4 modified Ashworth score. When you use 6 vials, you go down 6, 8 vials, 7. And that means when you count all joints, so we are in that we use the repass scale where we count up a quantification of spasticity, and therefore there is a nice equation about when you use more, you get more effects, but you also get more function here. Percent of patients which can walk alone in the whole cohort. In the beginning, only a quarter could walk alone. And after treatment, 3 times high dose, about half could walk. Although it's real functional improvement. And this was goal attainment. And of course, the major thing was here, we looked at side effects. And what we found is no more side effects. So distribution of the toxin all over the body, that could be reflected by dysphagia from botulinum toxin, because when you inject here and the toxin gets, moving, it could go here and create dysphagia. But as you can see, with the lowest dose, 5 patients claimed this dysphagia, and with the highest dose, 2 claimed dysphagia. So there is no correlation between the dose and dysphagia. Okay, accuracy of injection. Actually, I showed you ultrasound guidance is recommended. Targeting end plate zone, very specific. We have muscles where the end plates are very distinct in certain places. Then we have to inject in that place. But on the other hand, it spreads a little bit. There is a diffusion, but the bottom line is you should not inject more than 50 units of botulinum toxin, which is the magical botox, or 50 units botulinum toxin, which is the German toxin xeomin, or 125, which is the former British toxin Dysport, botulinum toxin. So that's actually the bottom line. And then you can try to target the end plate zones. And my friend Jean-Michel Grasses and David Simpson, they published when you inject directly in the end plate zones, you get better effect than when you inject in distal aspects of the. So these are the end plates. There is in the forearm for the pronator teres and for the flexor carpi ulnaris, there are end plate zones, but also for the flexor of the thumb, there is no defined end plate zone, though therefore we usually put 2 injection points. And then there is the most important for myself, the adjunctive therapy, and a systematic review of Patricia Mills from Vancouver, nice lady from Vancouver, now is in a different business, not in the neurologies. She published that there is high-level evidence to suggest that adjunctive therapy may improve outcome following botulinum toxin injection. And an Italian group, Alessandro, published that actually it should be like you should have a specialized program for every joint when you inject. So your team should know when the physician injects the bicep, they should know what to do on the time scale and the measures. That would be the most effective. So now a very important point. My last publication dealt with that. Spasticity associated pain, more than 60% following stroke. This was the cohort. That was the distribution of pain. Distribution of pain means on a visual analog scale, 10 is the most pain. You can imagine 0 is no pain. Only 25% of stroke patients from a cohort of 272 had no pain. The others had pain, and there was a correlation between spasticity and pain. And these are 2 placebo-controlled injections, and this is pain reduction. This is pain reduction in placebo. There is a placebo effect. And this is open re-injection. Also, the patient that had placebo before then had pain reduction. Significant. So therefore, botulinum toxin made it on the Times magazine. A drug that can treat everything. I don't agree, but it's very effective in treating increased muscle tone and also other features of upper motor neuron syndrome. And the recommendation is we should treat much earlier than we did in the past. And recommendation, Raymond Rosales published a systematic review about all studies that were published about early injection. What is early injection? Before 3 months. So we did a study in lower limb, placebo-controlled, and we could show that patients don't develop pes equinus when you inject before 3 months. You have a chance to avoid this pes equinus or pes equinovarus. And I think that's the last thing I should manage before I go in pension, making the orthopedic surgeons without jobs in that way. Altogether, we should treat the positive signs of the upper motor neuron syndrome with botulinum toxin, ITB, casting. You don't see any oral drugs here. And we should use modern training modalities, could be exoskeletons, but also could be hands-on, much better, and physical treatment. And of course, I put that here, the best in life is not what you can buy for money. But on the other hand, Botox costs a lot, so we have to think about it. So we have to spend a little money here. Yeah. So these are the people I work together. First place, Bettina. And I think that's the message. Thank you. And I made it in 1 hour. Yeah, hopefully you have a lot of questions. We are happy to answer. We are happy to answer.
Right.
If
I'll
not,
ask a question then. What about the role of advanced practitioners or physiotherapists who administer Botox, prescribe it, administer it? Where are you at with that in Germany?
so usually British are more conservative than Germans, but in that way, British are maybe on. So a lot of German physicians says on the wrong track. I'm not on that part of the discussion, but I think it's so there are so experienced physicians that are saying this. So of course we have to hear them. On the other hand, they are so bright physiotherapists, occupational therapists, they are keen to learn it. And they know so much about the patient. Why shouldn't they handle this procedure and that drug? On the other hand, this is, as I said, per weight, this is poison we have on Earth. Actually, in the end, the US invaded Iraq because they suspected botulinum toxin production, but they found Botox vials. So there is still a discussion. of course, we also should discuss why the British do that, because they have not enough doctors to do the job. So if it's an increase in quality, we should do that, yeah. But if it's just, you know, I'm very cautious with the quality of work that should be delivered to disabled people.
Mhm.
I think that's my answer.
Yeah, well, it's very nice to see that the evidence is coming now that earlier is better, because normally when people are referred to a spasticity clinic, they have profound contraction, and contraction is the bigger problem to treat them. And we know that passive movement positioning, there's very little studies out there, but you need so much of it that it isn't feasible to deliver, and it gives very poor margins. So then you get into your serial casting, where you get much better ranges of movement, but you haven't addressed the underlying issue that caused the contracture. So then you go back to contracture. Yes. So I think it is really important that the therapists pick this up really quickly early in therapy. They recognize spasticity very early on and would be well placed to highlight it. And indeed, I would hope in the future to treat it. But so that's the first thing. The second thing I wanted to ask you, because somebody asked me recently and I didn't have a good answer for them. As therapists, we use weight-bearing activities a lot to decrease spasticity. And the mechanism for it, or how it works, I'm not clear on. I wonder, do you have any insight?
Mm-hmm. Yeah, so when it comes to the bottom line, how or why physiotherapy or occupational therapy works, it comes neurophysiologically wise to the fact cause they apply stretch to a muscle that then feeds 1A afferences to the spinal cord that inhibits the alpha motor neuron. That's it. And there is kind of a map with reversible treatment, permanent treatment, focal and generalized treatment, and where you put physiotherapy, occupational therapy, to reverse, and focal. How reverse? 5 minutes. So that's what you can do, of course, though that means to really change the excitability in the spinal motor neuron pool, you have to put someone in a standing for an hour. Mm-hmm. Then in this machine with verticalization for an hour, and maybe another hour physiotherapy on the ground, and another hour occupation therapy for the upper limbs, and then you manage spasticity in a generalized TBI patient for that day. And it will not bring anything for the next day. In thought in neurophysiological explanation, but in terms of muscle texture, collagen, tendons, it counts a lot because you stretch the material which is inert, and the stretch will work. And therefore, of course, doing fasciotomias is not permanent, but it helps a little longer than botulinum toxin. So I have a lot of patients that got this fasciotomies, which are very hip, but that's a non-permanent treatment for maybe 6 months, and then it's gone in the most. When you really want to lengthen, then you have to put, of course, tenotomias. And I had a patient yesterday who got an Achilles tenotomia, and it was too long. Now he's too weak. Yeah, yeah. So that's a very difficult job, actually.
Well, it's never a good idea to cut a muscle. I think. When you look at the effect on collagen and collagen alignment of immobility, you see that becomes more profound the longer the immobility stays there. But after a number of months, it's the arthrogenic changes that are more profound, certainly in the preclinical studies.
And therefore it would be...
So who's doing anything in the joint once you get to that point? Nobody really. Because you cannot make a joint unstable. You can cut the muscle around it and cause a neuromuscular instability, essentially, is what you're giving it. But nobody is going to the joint. And once you get to 4 months, you have arthrogenic changes that aren't reversible.
So therefore, it would be the best to change protein synthesis after a TBI. So actually, though, we're talking a lot about the neuronal changes and the networks in the spinal cord, but the most important thing would be to stop change in muscle properties. That would be the major thing. We don't have any handle here, no tool. So there were big studies, gene analysis, what changed in muscle. So they looked to all proteins and they could identify protein changes. Maybe in the future we get a new rituximab for the muscle to stop this. So that's a hope, but we don't know now. So a generalized infusion to stop muscle shrinking or tendon shrinking, because that's what we cannot avoid with focal treatment. And of course, the therapist has to use a lot of force sometimes to stretch, to hold, and the patients, when we cannot listen to them, when they cannot speak, and when we don't look to, or when we don't look to their pupils that goes like that with a cast. So pain could be also a big thing in treating contractures in people that cannot speak.
So, is there any simple way to recognize, basically without an X-ray, difference between contractures and spasticity, just by palpation?
Good question. Very good question. So we discussed a lot, and for the Achilles tendon, it's only standing an hour and looking whether there is something that's, improves. So that's the ability. So actually compliance would be a nice word for that, or the compliance of the texture. Maybe it's not the exact word. So the resistance. So though there is, so you test the resistance of the contracture. And usually what I do, I inject botulinum toxin, because you cannot. So to distinguish between the tendon, or let's say collagen, and the muscle activity, of course you can use EMG, but who's doing that? Not only a few centers. For example, here what you can do, you can put botulinum toxin, so it's reversible. So what we usually do is, when we suspect contracture, we stretch, and if it's not successful, we put 2 vials of botulinum toxin in the muscle, and then we stretch again. Then we are doing regression measures, so forced regression. We'll see a case soon. So Bettina will present a patient we had together. So that's what we do. And in the end, sometimes I have to phone with the surgeon.
I think before years ago, we not have not so good much management in botox and therapy since we have now, because we always running after the spastic. So now botulinum toxin starts earlier in the treatment, and the therapist making functional stretching with body weight on the joints and not only stretching in this position. it's much more effective to make functional stretching in all movements. So thinking about start the therapy, how early you can in the multi-professional team, and also what we see, the combination of robotic functional therapy and other things. If we have a rhythmic movement, the spastic will reduce. And then it's important to recover it on the floor, walking or make something normal movement. Yes.
Ich habe keinen Stick eingestellt.
Ist der Kann man sagen.
The level that the backbone comes at, that make a difference. They're all in the same site.
Yeah, so actually you can do a